All right, I'm Danish Bari, and let's review chemodenervation for blepharospasm and hemifacial spasm. So, blepharospasm is a focal, and although it's focal, but it's usually bilateral, dystonia of the orbicularis oculi muscle that leads to an involuntary eye closure. And often the patient complains more about difficulty opening their eyes, that the eyes are shutting down on them and they have to really pry hard or make an effort to open their eyes. And it happens more in certain situations than others, and it waxes and wanes. All of that is very typical of a dystonia. Dystonia is never a fixed abnormality. So similarly, blepharospasm is not a fixed spasm, but it is a spasm that comes and goes, and in certain times of the day, bright light or dust or something like that, and they start having even more spasm and even more difficulty opening their eyes. Prevalence is reported to be 16 to 133 cases per million, and incidence is most common primary focal dystonia is blepharospasm, almost 1.7 in 10,000 patient population. Slightly more common in women than in men. Mean age of onset is in the 50s, but younger age can happen. Risk increases with age and has an association with Parkinson's disease, with dystonic cerebral palsy, and tardive syndrome or tardive blepharospasm are associated with it. So here is a patient showing the serial effect of chemodenervation on blepharospasm. You can see right after injections on week 1. On the top left of the screen, patient has eyelid drooping with eyelids covering most of the cornea, and most of the pupil is covered. In week 2, you can see some improvement, although patient may be looking slightly up towards the camera, but still you can see that the eyelid are touching or covering part of the pupil. Week 6 is significantly improved, where pupil is mostly visible. These are taken self images, taken selfies taken by the patient, so not of the best quality, except for week 1, which was probably a clinic image, and then week 7. So clearly, chemodenervation can improve the eye opening in someone with blepharospasm. There is reasonable evidence available for recommendation for using blepharospasm chemodenervation. 2008 review showed botulinum toxin injections should be considered as treatment option as a level B evidence. And then in 2013, an updated review showed level A recommendation for botulinum toxin A, both INCO and ANA. So that will be Botox and Xeomin, and level B recommendation for EBO type A, which is Dysport, and unknown recommendation for type B, which is Rima botulinum toxin B. Suggested starting dose for blepharospasm, a dose is per eye. In for botulinum toxin injections or Botox, onabotulinum, it's 20 units per eye is a recommended starting dose. So you can split it as 5 times 4 or 2.5 times 8 or whatever combination you want. It's slightly higher for Dysport and MyoBlock, just because the units don't correlate exactly the same. Now, once you have started with that dose, then you sometime increase the dose because of lack of response and end up being with a maintenance dose for most of patients. So if you just focus on the onabotulinum toxin A or OBTA, recommended typical dose is about 12.5 to 20 units per eye and 1.25 to 5 units per side, 2 to 5 sites. And then often the subsequent mean dose after a few injections is about 30 units on each eye. So almost 60 units or so. Range is 25 to 50 units on each eye or 50 to 100 units per patient. And then maximum dose is usually around 100 units or less. Some causes of blepharospasm needed much higher dose than others. So patients who have blepharospasm caused, for example, from tardive dystonia, often require much higher doses for blepharospasm compared to the other patients who may have underlying muscle disease or problem, or blepharospasm from other causes or indications such as Parkinson's may require a different dosage. But a primary idiopathic blepharospasm, often they don't require more than 100 unit on each eye. That means that you are doing something wrong. They start having side effects from it at that dose. Other drug preparation doses also written on the slides for your review. All right, so injection sites. These are some common sites that are recommended. Some of the textbooks or handbooks written for injections. So Orderson is a very commonly reviewed handbook for botulinum toxin injections, published in 2008. There are 4 sites recommended: 2 on around the eyebrows, median and lateral end of the eyebrow, 2 on the inferior eyelid, 1 in the middle, and 1 on the lateral edge, almost in vertically aligned with the upper eyelid or eyebrow injection. These injections, if you pay attention, they are not really going towards the eye, especially the upper eyelid or close to the eye, and they're staying away. The orbicularis oculi muscle is a very broad muscle. It goes from the eyelids, upper and lower eyelid, all the way to the orbital fossa or the orbit, where the eye is sitting. So the orbicularis oculi is all the way up here in below the eyebrows and below the lower eyelid and below the eye and all of this area. So you can inject these part of the muscles of orbicularis oculi. Sometimes we call it a preorbital or preseptal or preorbital part of the muscle. And then the one that is right on the eyelid is called pretarsal or pretarsal fibers of the orbicularis oculi. So here pretarsal fibers are not addressed or injected by Alderson recommendation. By Jost in recommendation, now you can see that these are specifically addressing the pretarsal on the medial and almost pretarsal on the lateral fibers or slightly above, but it is pretarsal medially on the lower eyelid, but and then more often preorbital fibers on the lateral eyelid for the lower eyelid by Jost. Similarly, Alter and Wilson initial injection site recommended are somewhat similar to Jost, maybe more middle on the lower eyelid and not internal is the main slight difference. But Alter and Wilson also recommended multiple additional sites were recommended by Alter and Wilson. And they, you can see the primary sites in red and then additional sites in black and white crosses spreading all over to different parts of the orbicularis oculi preorbital fibers. So Childers is something that I have mostly followed, maybe because that's how I was trained. It just kind of made sense. It was simple to me, and I can explain this a little bit more as I go in details. In general, the idea is to give 4 outer injections. So one on the medial eyebrow, one on the lateral eyebrow, then one laterally around the preorbital fibers here, and then one inferiorly. So those are the 4 preorbital injections, and you can do them with or without the 2 pretarsal injections on the upper eyelid. So one medial pretarsal and one lateral pretarsal. So that will be 4 to 6 injection. That's my typical injection plan to start. With some caveats, I don't always add the pretarsal ones, and I don't always add the inferior eyelid one, and I will explain that based on evidence in the next few slides. All right. So should we do preseptal or preorbital fibers, or should we do pretarsal? Should we add or not add pretarsal every time or not add it? So here is one study to look at it objectively. This was an unblinded study. It was a small study, and there were alternating sites. So 25 patients, 186 treatment sessions done, and pretarsal Botox A was produced that was given on a pretarsal fibers on some session, and the other session they get preorbital. So some session pretarsal, some session preorbital, alternating. And they found that the pretarsal injections gave a higher response rate and a longer duration as compared to the preorbital injection. However, and side effects were more common in the preorbital or preseptal injections. Same thing. And they concluded that the pretarsal injections alone are sufficient to optimize outcomes. So you don't even have to do the orbital, just do the pretarsal injections. So I do consider adding pretarsal very frequently if I see very clearly that there is no pretarsal involvement, then I may skip them. Otherwise, by default, I will just add them. The way I was trained was that the pretarsal fibers do this closing of the eyelid. So this one, while the preorbital one does the squeezing of the eye. So if you see squeezing of the eye, but not so much a problem opening the last step, then maybe you can skip pretarsal just to preorbital. Or if you just see pretarsal involvement and not that much squeezing of the eye around, then you can just do the pretarsal and skip the preorbital. I think it's hard to examine in patient and it can vary. So I just do the pretarsal to begin with. Unless, as I said, that in very few patients where I have a clear indication that there is no tarsal involvement and it's just really the squeezing that is becoming a problem. Now, injection sites, does they matter? I showed you different injection sites and location. Price et al. In 1997 looked at 50 patients with a mean follow-up of 16 months, and there were differences on the benefits and side effects that were dependent upon the injection sites. The closer to the eyelid margin the injection was done, the higher the risk of side effects. And here the side effects are things like dry eyes or irritation, and that may be because that margin of the eyelid is required for closing the eye properly, so that there is no width or some or space left between the eyelids when you blink or when you close your eyes, so that there is no dry eyes that happen or loss of the tears happen. Similarly, when you do the medial injection, sometime if you're too close, you can cause the drying of the lacrimal gland there, or you can cause the tearing of the eyes from there. So a little bit lateral, little bit higher, not right at the margin, will be better to do the medial injection. Inner orbital injection produced ptosis in 13% of the patients. Best combination was true pre-tarsal and two lower lid injections, was as per the Price et al. Study in 1997. But there was more ocular irritation. So when you're doing the medial tarsal injections, do them not very close to the eyelid and not close to the edge of the eyelid or close to the medial end of the eyelid, and a little away from that. Lower eyelid injection. So in a double blind small study, 13 of the 15 patients that received saline in lower lids had a relief of spasm for the same duration as receiving toxin. So maybe just a placebo response. Authors concluded that the lower eyelid injections might not be needed at all, based on that they respond just to poking and not necessarily to the drug or to this fluid. And others have noted that the patients do not respond to upper eyelid injection alone, and you have to add lower eyelid injections for these patients. Another caveat with the lower eyelid injection is that the lower eyelid, it forms like a cup to try to catch the tears coming down by the swipe of the upper eyelid. And if that lower eyelid, if you do the injection higher, closer to the edge of the lower eyelid or right on the pretarsal fibers, then you can sometimes cause eversion of the lower eyelid, just like that. So you can start seeing the pink of my lower eyelid. And that eversion means that the cup is not really sticking to the eyeball very well of the lower eyelid, and there could be excessive loss of tearing and excessive dry eyes. For that reason, my personal bias is to do injections if I'm going to do lower eyelid. I don't always. In blepharospasm, pure blepharospasm, I often skip the lower eyelid injection. I do the lateral one here, maybe more laterally than here. But you can do it here, you can do it laterally here, but I skip the middle one or the medial one completely. Definitely no medial one, and I often skip the medial one. If I'm going to do the middle one on the lower eyelid, I will do them lower, as close to the orbital edge as possible, to avoid some of that eversion of the lower eyelid and dry eyes that will happen. All right, another tip to remember is to avoid this midline of the upper eyelid. There is levator palpebrae superioris, which is also help with lifting of the eye. Not orbiculus oculi closes it, but gravity also closes it. So you not only need levator palpebrae superioris against the orbiculus oculi, which you are weakening anyways with your injection, but you also need it against gravity. And if that muscle gets weak, then the gravity might pull the eyelid down and cause ptosis, excessive, especially if there is excessive skin fold available on the present on the upper eyelid. So you want to do it at the ends of the eyes, so right here, separately, and I direct them away from the midline. So when I do injections here, I will direct them this way. When I do injections here, I will direct them this way, so that they are directing away from the midline, not towards the midline. And that way I will try to avoid this midline here and don't want to inject there. Starting dose can be 2.5 to 5 units. I used to start 2.5 very often. Now I often start with 5 very often. I found that 2.5 unit patients often needed escalation, maybe 70% or more. And even those who were not asking for escalation, I wasn't sure if the response was very robust. So I am now doing often 5 units of Botox, 4 sites minimum. So 1, 2, 3, and then 5 sites. So 3, and then I often do pretarsal. I often skip this site. So 3 outer and 2 pretarsal, and I skip the lower eyelid. That's my typical injection to start with, and I typically avoid the lower eyelid unless there is a specific reason I want to add that. Other tips to adverse effects are usually mild, and so especially includes dry eyes, which is the main problem that can secondarily cause blurred vision that is related with tearing, loss of tearing. Ptosis is not very common, to be honest, and ecchymosis or blood under the skin is also not very common if you do these injections carefully. You want to avoid the dry eyes basically. To avoid the entropion in lower eyelid sagging, avoid injection closer to the lower central eyelid, do them lower or not do them. And you can also avoid medial lower eyelid injection, which is very important for tearing. So I have never done them. To avoid ptosis, inject the upper eyelid away from the centers and directed them away and not direct them towards the center. Okay. And then for the dry eyes, you can routinely recommend patients to put drops in their eyes, like normal saline drops or artificial tear drops. And you can just tell them to go buy and use it for the first couple of weeks after the injections. And it can be just a routine because 10 to 15% of patients have reported dry eyes in the studies. All right, so hemifacial spasm is somewhat similar in terms of injection planning, but not exactly the same. Injections are different for hemifacial spasm as compared to blepharospasm. In blepharospasm, both eyes are involved. In hemifacial spasm, one face is involved. So eyes commonly, but also often lower face is involved. Hemifacial spasm is a peripherally induced movement disorder, one of those very, very few, maybe 2 or 3 movement disorders which are peripherally induced. It is characterized by involuntary, intermittent, fast, clonic-like synchronous contraction of the muscles innervated by the facial nerve. And sometimes it's also called clonic spasm. It is usually unilateral. Prevalence is around 1 in 1,000 or less. When etiology is found, is most commonly a vascular loop compressing on the 7th cranial nerve. Treatment of choice is chemodenervation. Even in those patients of mine where I found a vascular loop through thin slices through MRI of the brain or the brainstem, and the blood vessel loop was touching the 7th nerve, they did not want to go for a surgery to move that blood vessel away. And I do not, make them at fault. 2008 AAN's evidence-based review concluded that botulinum toxin is effective minimal side effects treatment for hemifacial spasm. There was one class 2 and one class 3 study, and they Botox and Dysport after dosage adjustments are probably equivalent, although there is no clear trial on that. The class 2 study was a randomized placebo-controlled crossover 4-arm study on 11 patients with dose-dependent benefits on botulinum toxin injections. Mark Hallett in 2013 did a review and gave it a level B recommendation for ONA botulinum toxin, and C for abobotulinum toxin, and U for unknown for INCO and rimabotulinum toxin B. Injection sites are specific to each patient's phenomenology, so you have to kind of see where the twitching is happening. Twitching can happen around the nose, can happen around the corner of the lip, on the outer edge of the lip, outer corner or upper corner here. It can happen lower, it can happen out here, it can happen down here. So where exactly the spasm is happening in the lower face is important for injection planning. Similarly, eyes are often involved, but it may be that the upper edge of the eye was involved more and lower is not involved, or both upper and lower are involved, or it may be only eyes involved and face is not involved. So all of that will decide where and how much injections you want to give. Initial dose is typically around 20 to 30 units, maybe 35 units or so on one side of the face. If you're just doing the eyes, you can just do 20 units. If you're doing eyes and lower face, you can do 20, and you can add 5 to 10 units on the lower face or so. Again, it depends on severity of the contractions and the amount of or number of muscles involved. Less is best. You don't want to cause too much weakness when you start. Usually you can start with 2.5 to 5 unit. Often around eyes, I do 5 units, but lower face, if I'm doing any part of the face injections, I often start with 2.5 units. If you're doing 5, you want to do, often I do pretarsal units at the same time as the outer one, but you can skip them if you're not seeing significant pretarsal involvement. If it's mostly around the eye, mostly the blink is around the orbit or so. If there is lower face involvement, there are certain muscles that you can inject, but you have to be careful. Anytime you inject a face muscle, it can cause weakness and paralysis will end up causing loss of expression, loss of resting expression. So the folds that you see, my eyes fold that you're seeing, my nose fold you're seeing, they can flatten out and disappear. And we human has a significant propensity to look at faces. We have a special area for that. So that's why facial expressions are important to us, and we are very fine-tuned to picking up mild abnormalities on the face. So anytime you cause a mild abnormality on a patient, especially if it's a female patient, many of their friends will tell her that, what's going to happen to your face, why it's flat on one side, or what happened, did you have a stroke or something like that. But even in men, especially with significant use of toxin, you can cause significant drooping and really looks like a stroke to anyone. It doesn't have to be a trained person. Even kids will say, your face is drooping, did you have a stroke or what happened? But if you are interested and are feeling bored, these are some of the muscles I highlighted that you can target. You can target the levator libi superioris. That's a muscle that runs from the middle of the one half of the lip, right middle, along the edge of the nose, going up towards the middle of the eye, going down from the eye down to here. And that muscle will cause a pulling like this and will cause a deepening of the nasolabial fold. The fold become very deep and pulled, and kind of a squeezed fold like that will happen. You can also inject zygomaticus. Zygomaticus run from the edge of the mouth towards the edge of the eye, and so one will go like this and one will go like this. They often have two arms, major and minor, and you can inject them. And usually I inject them away from the corner of the mouth, right about here, halfway. More closer to the corner of the mouth you inject zygomaticus, the more likely you are to cause the drooping of the corner of the mouth. Another one is levator anguli oris, goes from the angle of the mouth out towards the edge of the eye. So it's sort of like zygomaticus, but not as horizontal, but more vertical. And you can also inject that. Levator anguli oris, zygomaticus, and then risorius goes more towards the tragus, so more flat. And this is the muscle that will cause this. So someone really have pulling like that, and you need to relieve it, then you need to inject the risorius. But this will be the one most likely to cause drooping of the mouth. So you only inject it if you're for sure there is risorius involvement. Many injectors, if they're injecting risorius, will also inject a half the dose on the other side, sometimes even equal dose, to cause drooping on both sides of the mouth, so that if they are drooping on one side, it's not, it's more visible, but if it's drooping slightly on both sides, it may look like they're just sad and they have a they have a sad expression. So avoiding facial asymmetry is the biggest challenge for injecting the lower half of the face. All right, so this was the quick summary of injections for blepharospasm and hemifacial spasm. In summary, chemoderivation is a treatment of choice for blepharospasm and likely for hemifacial spasm because there is no curative measures we know of. Treatment is has significant level of evidence, although not classic level A that we want, but there is significant level to show yes, it does work, and our personal experience also supports that. And dosing should be conservative and avoid some of the common side effects I've mentioned. Thank you so much.